Dr. Sandeep Shetty is a consultant neonatologist at St. George's Hospital and an honorary senior lecturer at St. George's University of London. His research interests include novel mode of invasive and non-invasive ventilatory support with focus on Neurally Adjusted Ventilatory Assist, NIV-NAVA.
Thank you, Editor. As you know, BPD is a very multifactorial disease. So although we are getting better at improving survival rates of very premature babies, the trend of BPD in the last decade has not really changed. And the management can be classified broadly in the perinatal management, immediate neonatal period, and weaning of invasive and non-invasive ventilation. When I talk about perinatal management, we're really talking about delivering of infants in a tertiary center. So we know there is enough evidence that a baby who's premature, born in a level 3 unit, has a better outcome. So there is already a lot of work done at the network level where there is in utero transfer as rather than a postnatal transfer or a preterm baby. The second thing, which as a perinatal factor where we can make a difference, is the antenatal administration of steroids. So this, we know that it not only reduces the duration of mechanical ventilation, RDS, and improved lung maturation. Hence, even at St. George's, what we've done, there's improved work and increased uptake for antenatal steroids, and hence there is a better, instead of mid-80s, we've increased, our current uptake is almost high 90s. The other management that can be looked into in the immediate neonatal period is things like delayed cord clamping or temperature control and maintaining of the temperature chain using, for example, transformer, using a blended oxygen and avoiding mechanical ventilation as much as possible, and thinking of alternative methods like CPAP, and also thinking of alternate methods of administering surfactant like LISA or LISA. The weaning from mechanical invasive ventilation would be the third step in reducing the whole impact of BPD. What we've really worked on is the change in mindset and how BPD infants are managed, or preterm infants are managed in the initial period. This would mean really that previously it wasn't that long ago where a 25-weeker initially was being managed by intubation and ventilation at the outset, but now there is a cultural shift in thinking of alternate methods, early CPAP, thinking of LISA in the early delivery suite, and managing therefore their own after that. We've also thought about bringing in BPD quality improvement checklists. So that was basically standardizing the practice and the management of preterm baby does not vary depending upon depending on the different clinician, for example. So the first week strategy would be early intubation, early nutrition. Second week strategy would be thinking about, if the baby is still ventilated, thinking about does the patent ductus arteriosus or the PTA needing treatment, fortification of the milk once you've reached full feeds. And the third week, thinking about steroids in aiding in extubating these babies. And at the tail end, when they are reaching the correct age of 36 weeks of gestation, we're really thinking about, are we too slow in weaning? What are the other management strategy that is needed to help this baby to come off that respiratory support this infant needs? So all in all, there is a lot of work being done in order to reduce the BPD impact, and as BPD is an important comorbidity factor in preterm babies. With LISA, we have on the neonatal unit at St. George's, we have used it since 2017, 2018 onwards. We've already done over 50 to 60 preterm infants. We performed LISA technique, and we've published our data where we compare 25 LISA infants where LISA was performed either in delivery suite on the neonatal unit with historical cohorts matched for birth weight, gestational age, and antenatal steroids that was given. And we found that the duration of ventilation was the rate of intubation was significantly reduced in the LISA group, and the BPD rates were reduced in the LISA group compared to the historical cohort. And this article has been published in the American Journal of Perinatology, and this is in keeping with multiple other meta-analysis studies where the BPD rates were known to be reduced with LISA technique. So, as we know that from recent evidence that we have, is volume controlled ventilation certainly a preferred start mode of ventilation compared to a pressure mode. There is no hard evidence that high frequency ventilation is better than the volume controlled ventilation. So our standard start mode of ventilation would be volume controlled ventilation, and from that point of view, so we would start. In addition, at St. George's, what we offer is an invasive NAVA mode of ventilation, where we found, we published data around looking at reduced extubation failure rates, failure rates in terms of extubation. In addition, what we've looked at is basically we've bench tested different ventilators so that we have a standardized approach in managing these preterm infants across intensive care rather than having 2 or 3 different ventilators. Not suggesting that one ventilator is better than the other, but certainly looking at the standard approach from one ventilator, and at St. George's, we've got the same ventilator across intensive care and high dependency unit, offering both invasive and non-invasive modes of ventilation. In addition, we have the ventilation team, where for the complex ones, where there is a week-on-week discussion, where complex BPD patients, week-on-week discussions around how to wean the non-invasive support, change over to portable ventilator, transition to pediatric intensive care, weaning of home oxygen. All of that is discussed on a week-on-week with 2 standardized approach as well. So, in terms of ventilation team, we set it up around 2 or 3 years ago, where we have a mixture of doctors, respiratory consultant, long-term ventilation team, and nurses. So we, on a week-on-week basis, on a regular basis, we discuss the complex patients and really looking at the strategy in weaning and what are the other ventilation modes that can be offered. We have also considered the nutrition of these babies, transition to pediatric intensive care, transition to portable ventilator, and also home oxygen weaning. So that's an interesting concept, and we've had good feedback. So that because there is a consistent plan of message that is given to the family. We know that there are different modes of ventilation in terms of pressure and volume, and there is evidence on the modes of ventilation. The volume-controlled ventilation is the preferred start mode of ventilation as per the evidence that is there, and hence that is the standard mode of ventilation that we use on the neonatal unit in managing BPD infants or preterm infants. So the ventilation parameters on initial standard mode for a preterm baby is volume control mode of ventilation, 5 mL per kilo, with a reasonable Pmax, that is the maximum pressure that is allowed, and backup rate around 40 or 50 with a reasonable I time of 0.38, I would say. In terms of there is no clear evidence that high frequency is better than volume control, and so our standard mode of ventilation would be a volume controlled ventilation from that point of view. And In addition, what we offer at St. George's is an invasive NAVA mode of ventilation in some of the infants, some of the preterm infants. What we also have done, it's an important point to think about, is the standard practice using ventilators. So we bench tested, when we were changing our ventilators, we bench tested all the ventilators, not suggesting one is better than the other, but really picking and choosing what is suitable for the neonatal unit that you're working. At the moment, we have the same ventilator across ITU and high dependency unit, offering both invasive and non-invasive mode of ventilation. Making it slightly, making it, as I said, standardizing the practice in managing these preterm infants. If, for example, a baby is approaching week 3 and week 4 with evolving bronchopulmonary dysplasia, then we tend to include the ventilation team in management of these complex BPD patients. Well, we know that there is no standard the strategies, particularly during weaning, which involve changing from one form of non-invasive support to other, needs greater evidence base. At the moment, what we've done is basically we introduced a care bundle, and where we're really thinking about the circuit change due date when thinking about moving from one non-invasive mode of support to the other. So, for example, it was not uncommon in the initial, in a couple of, around 4 or 5 years ago, where a clinician might have changed the non-invasive support from high flow to CPAP and then BiPAP, and we're wasting a lot of circuits and possibly staff time, and cost effectiveness wasn't the best with that. So we introduced a care bundle where you factor in the circuit change due to decide from moving from one circuit, let's say from CPAP to high flow or BiPAP to high flow, where you factor in the circuit change due. So this quality improvement project was then published in Advances in Neonatal Care Journal, where we show that there is a cost-effective benefit of around £17,000 per year, not factoring staff timing in terms of this kind of change. So it's been quite well received, and our standard practice in terms of weaning non-invasive support. Well, NAVA, as you understand, it stands for Neurally Adjusted Ventilatory Assist. So what happens in here is there is a modified the nasogastric catheter, which is placed instead of your nasogastric tube. So this tube can be used, this catheter can be used for feeding. In addition, this catheter has electrodes which sits at the level of diaphragm, which picks up the initial signals of breathing from the level of diaphragm. So what advantage of this is it sends the impulse signals to the ventilator, and the ventilator then gives pressures based on the effort made by the baby. So in a sense, it is much synchronous in terms of how these infants are managed. So of course there is a backup setup if the baby is not breathing, so completely safe from that point of view. In terms of, I initially started working on NAVA mode of ventilation since 2013, more in research context. And I was fortunate that at St. George's, we were able to offer NAVA mode, both invasive and non-invasive mode, as a standard of care for some of the complex patients. So invasive mode, we're really talking about infants who've been on the ventilator for beyond the 3 or 4 weeks, evolving or established bronchopulmonary dysplasia, still ventilated, then getting that synchrony. So we really published submitted our data to Early Human Development recently, where we compared our 18 infant historical cohort, and we found that the duration of ventilation, extubation failure rates are significantly lower in the NAVA group, and also the length of hospital stay was in favor of the NAVA group. So far we've already done NAVA on at least around 38 to 40 patients, and this staff on the neonatal unit are getting more and more comfortable offering this as a standard mode of care. Other piece of work that we've done is what we're currently looking as the less use of sedation, or possibly better nutrition, better weight gain. If you're not spending as much energy, but better synchrony, then are we having better weight gain? So those are the other aspects of potential research that we're looking at on the neonatal unit. So. Essentially, I feel both NAVA and both invasive and non-invasive, is a promising mode, and there is growing interest in this particular mode of ventilation. This is something that neonatologists may use widely in the coming years. That's a very good question, basically. So, in fact, offering NAVA is more of a team discussion than randomly giving, offering to anybody, because there is cost of, we have to think about the cost as well. But particularly for parents, the usual feedback is how comfortable the baby is. In fact, you would ask, we sometimes find other patients asking us, when are you putting our baby onto NAVA? It's more about the comfort level, the synchrony, how much you find that it's all contributing the overall improvement in how the baby is doing, because we know that it's not one standard pressure that is needed with breath and breath, and that facility of variation in pressures helping with the breathing really is a promising aspect of NAVA.